Hello, everyone. Welcome to our series of CPD. So, as you know, that we have international presenters from different countries. So, I try to just take their some of the time. So, everybody has approved my request. So, today we have Dr. Foster Joseph. She is practicing in UK since long time, and she is working as a senior physical therapist in MSKD here, which is quite amazing and a proud for us as well. We have Dr. Amna Jafar. She is practicing as a physiotherapist in UK as well. So we have two candidates. Majority is from United Kingdom, which is nice, and we have Dr. Uswa Ramzan. She is practicing as a physiotherapist in Australia. So, and I'm from New Zealand. So me and Uswa somehow we are in neighbor, but yeah, two people are in majority from UK. And today we have presenter Dr. Foster Joseph. She will be talking about some brief introduction and overview on the anatomy of shoulder joint and the biomechanics and how altered biomechanics affect your patient's mobility, function, and day-to-day activities. So thank you, Foster, for sparing time for us. And yeah, we are excited to have you.
Many of us are excited to have you today as a presenter. Many people are, they will keep on messaging me. We want more CPDs from you guys. So,
Except
inshallah,
myself.
hopefully. No, you should.
Yeah.
So, welcome,
Thank you
girls,
so much. Yeah.
four physios from all over the world, mashallah. Basically, our roots are from Pakistan, and we are proud to be a Pakistani physiotherapist, mashallah. And thank you, Benish,
Yeah.
for a great introduction. Foster, good luck, and Uswa, thanks for joining us.
Thank you. Hello, good morning, everyone. This is Foster, and I'll be presenting a little bit of an interactive session on shoulder rotator cuff injuries. So we are all aware that the most common injuries in the shoulder pathologies we find is rotator cuff injuries. Uh, it can be traumatic injury or it can be an atraumatic injury. Okay, so when we are talking about trauma, so any kind of trauma, when patient had a fall, they've hit their shoulder, right? Or degenerative tears as well, degenerative injuries in which you count different tendinopathies and different calcific tendinopathies, etc. That could be age related, or that could be any overuse. For example, especially if patient have a lot of overhead activities, then that could all contribute to shoulder rotator cuff tears and injuries. So सबसे पहले we'll be sorry, I'm just talking in Urdu as well. We will be doing a little bit of assessment. So I'll be talking about minute assessment. Okay, what will be the common observation? What will be the subjective findings, your objective findings, and what are the special tests that you can use to differentiate your rotator cuff tears from your osteoarthritic presentations, arthrogenic presentations, or your labral tears. Okay. So, if we are talking about trauma, then what will be the subjective findings? That obviously pain, especially painful arc, specifically from 90 degrees, maybe some people might manage to 90 degree, depends on the extent of tear and trauma. Some people might struggle even from 50 to 120 degrees in rotator cuff. So, pain and loss of your function. And same in degenerative tears or degenerative tendinopathies, pain and loss of function. But what will differentiate from a trauma to a degenerative is that degenerative is more insidious onset and there is no history of trauma and it's gradual onset. However, in trauma, it's a sudden loss of function and pain. What will be the objective findings? The objective findings is, of course, your painful arc and decrease strength of your rotator cuff. You might notice a little bit wasting in the scapular fossa as well. So it's very important to ask your patient to like remove their shirts and have a proper look on the levels of the shoulder. You might feel a little dip on the fossa on the scapular fossa where your infraspinatus muscle attaches. Some special test. Now, I think the most confirmatory test for your rotator cuff tear is your empty cane test and your Hawkins-Kennedy test. But then you can use different tests. You can use specific muscle testing as well, like supraspinatus, infraspinatus, and subscapularis function. Now, it is very important to know the role of deltoid muscle as well. I'm going to draw, I'm using a pen, and so I'm going to draw a little bit of your muscle synergy to just give you a good understanding of what goes on. How to do the back camera. There it is. Right. So, this is your scapula. Sorry, guys, excuse the drawing. Right. And you've got your rotator cuff muscles. So, of course, this is the infraspinatus, and then you've got supraspinatus. And from front, you have got subscapularis muscles and teres minor over there. And that's your humeral head. Okay. So, what happens that these four muscles are your local movers of your shoulder joint. Now, you have got global movers as well. In your global movers, you have got, I usually use a formula of PLAB. So B is biceps, A is anterior deltoid, L is your latissimus dorsi, and P is your pec major. That's my formula to just remember it. PLAB. So these are your global movers. And then you've got global stabilizers. In your global stabilizers, you've got your, of course, your erector spinae muscles, which are your like spinal, paraspinal muscles, which support from here, from the medial aspect of your border. And then you have got tricep muscles. These are your global stabilizers of your shoulder joint. Now, normally, your scapula is whenever you're abducting your arm to 120 degrees, it will move in harmony, and it will, of course, interiorly rotate and sort of pronates as well, which is called protraction. Am I right? Protection of your scapula when you move. Now, what happens with rotator cuff injury, any kind of injury, any kind of tendinopathy, trauma, this synergy of your global stabilizers, your prime movers, and your global movers, this synergy will get disturbed. So I'm explaining what little bit about from the article what which Amna explained the other day. Now, what you've got like a full posterior kinetic chain. So you've got your latissimus dorsi coming from there that attaches to your humerus, and you've got your paraspinals. Now, this synergy, one, two, three, will be disturbed. And what happens that your posterior cuff muscles, which are your infraspinatus and teres minor, these are the first one to get inhibited, right? They get inhibited, and your plab muscles, your global movers, they get overactive because of improper mechanics. And your global stabilizers, they get underactive. Now, because of this disturbed synergy, the proper mechanism of your shoulder, the biomechanics will be disturbed, and it will overload your anterior rotator cuff muscles. And that can give you pain from repetitive overhead activities. This was just a little bit of introduction about the disturbed synergy between your shoulder prime movers, which are your rotator cuff, then your global movers, which are your plat muscles, and then your stabilizers, which are your tricep muscles and your erector spinae muscles. Now, when we do the yes, so we were talking about the special test for your rotator cuff. Can any one of you tell me about the special tests you can
Yeah,
use to
Hawkins,
differentiate?
Kennedy.
Yeah.
Hawkins, Kennedy, and MTK test you
Mm-hmm.
mentioned. Thank you.
Yes.
Thanks for revision.
What about you, Benish Shazadi?
Yes, empty cane test, full cane test, and supraspinatus belly press test you can do.
Yeah. Yeah.
And we can check the internal rotation by performing hand behind back test, which is quite a
Mm-hmm.
significant test.
Mm-hmm.
And And even just like, if we are individually targeting just the supraspinatus, so you will just follow the every movement which happens on the shoulder because of these four muscles.
Right. Okay. So now my personal, this is how I personally think
Good.
and now personally understand the biomechanics. So
Mm.
basically, imagine this is your humerus bone, right? And this is the tendon of your rotator cuff, okay, attaching to it. Okay. So the most position where it will be compromised and it will be stretched is your internal rotation. So when you internally rotate, so obviously your muscles are going to be stretched like that. This is why most of the tests involve internal rotation, and when you stretch it, you're going to feel the pain like your empty cane. So you internally rotate, of course, and then you're sort of resisting that. So you're already stretching the muscle, and you're then asking it to you're just pulling it tether and then asking to resist it as well. So that's immediately going to give you pain on your shoulder, right? First of all, trauma or degeneration, any kind of rotator cuff injury, it's important to differentiate whether it is a full tear. Because if it's a full tear, then the management would be different. You would either need an orthopedic opinion if it's going to be surgically treated, or if we are going to conservatively manage it. So to isolate the full tear, you've got two tests: your lag test and your drop arm test. Okay. So what you're going to do, you're going to ask the patient to abduct the shoulder to 90 degrees, and you're going to hold it, and then you have to tell them that I'm going to let go of my support, and you have to hold it there in 90 degrees. So the soon you're going to let go, the patient won't have the control and the arm would drop. This is the indication of a full rotator cuff tear. And
Yes.
your other
So
other
basically,
sign,
this is involved, yeah.
yeah. And then your lag sign. Your lag sign is your arm is going to be like close to your body, and you're going to externally rotate the arm, and you're going to ask your patient to hold it in that position. If they are unable to hold it and their arm just moves in a lag, then that's an indication that they've got a full thickness tear. So when you have a full thickness
Sorry,
tear,
could you tell me the positive causes for a full tear? Like, is it the
trauma,
outstretched?
any kind
Even
of trauma, like
trauma,
whenever,
yes.
yeah, trauma, when people fall on a foosh, it's called foosh, falling on an outstretched hand. If someone, I had a patient that was a weird atypical presentation. He was assaulted, so he
Oh,
got hit from behind. So
hmm.
instead of, but strangely enough, his shoulder wasn't dislocated, but he got a tear in his rotator cuff. It could be
Okay,
any
okay.
present, any kind of trauma, falling. Most of people fall and they have any trauma, any
I
assault,
think
but mostly
it's related to sports related injuries as well.
sport
Yeah.
related injuries. Yeah, yeah.
Mm. Okay.
So this is what you use to isolate your full thickness tear from your
Mm.
normal degenerative tears. Then you've got some muscle testing like your empty cane. I've already discussed. Hawk and Kennedy is pretty much the same as well. Internal rotation, about abducted. Your flexion is your elbow is flexed, and then you're internally rotating and asking the patient to rotate. This is for your Hawk and Kennedy. So these are all confirmatory signs that your rotator cuff is involved. Um, Now you've got some other signs as well. You've got some other tests where you can actually isolate if it's the posterior cuff that's involved or if it's the interior cuff that's involved. So for your posterior cuff, you've got hornblower sign. Do you know about hornblowers? So it's pretty much the same. Your arm is in abduction and your elbow is flexed
Yes.
90 degrees and you're externally rotating backwards and resisting backwards. That's your hornblower sign.
Yes.
Okay. That will isolate your teres
So
minor.
who will provide the
There's a
resistance? Like someone else, external source,
the
or
the, the
it's
physio
Yeah.
physiotherapist will give resistance and patient is going to resist against. So your hornblower signs. Then for your, like you have mentioned, belly press test for your subscapularis uh, tear, and also lift off test,
Yeah.
lift off, where
mm,
you move. I think you've already mentioned that, where, but I think you've taken the different name where you internally rotate your patient's hand and ask them to push against your hand. It's called the lift off test. That will
lift?
tell you if you've got any tear in your tear or calcification. I think all these tests are positive, whether if it's a tendinopathy or if it's a tear. I usually find them, all of them can come positive. But then you would have to isolate which ones are more positive and which ones are mild positive. Okay,
Hmm.
because obviously there's a little bit of element of all of those muscles involvement in every kind of movement. But when you isolate it, okay, the patient was, it was more provocative in the certain test, then Your clinical reasoning would be I'm more prone to think it's probably the posterior cuff that's involved. It's probably more the anterior cuff that's involved. However,
Mm.
the management is probably the same.
Okay.
When you conservatively manage, so for your full thickness tears, you would redirect the patient for an ultrasound if they need an imaging, because if they are young, then we need to see if what's the management's going to be. So after your imaging, if their goal is to return to high impact activities like playing rugby where they are going to have a lot of like elbowing and shoulder hit traumas, they might need a surgical intervention because they're going to go back to high impact activities. However, in old patients like above 60, where surgery is not going to have a good prognosis, or in patients with whom the goals are just to return back to their household chores and not many more, then the consultant might decide only to just do it conservatively. So, in your conservative rehab, you will focus more on deltoid strengthening then. Because when your rotator cuff is compromised, then your deltoid would take over.
Yes.
Okay, so for your deltoid rehab, you will be giving patients like lying supine, overhead, just to start a little bit of overhead mobility of your arm, and then you will slowly progresses from lying to high seating line, like which is also called high supine line, and then obviously to sitting and then standing, and then you add like the full kinetic chain, like Amna has discussed on the last CPD, which we were unfortunately unable to record. So then you
My
obviously
bad
you
luck.
you engage. It's okay, we'll give you a chance again. Then you will engage the full
Inshallah.
posterior chain. So that was the management of full thickness tear. Now your day-to-day rotator cuff tears, your symptom improvement test, I use them as a part of my assessment and as well as my
Okay.
treatment as well. And as you were
Yes.
saying that you have started using it, which is a good initiative and good step. So obviously, again, with your degenerative tears, subjective findings will be pain and loss of function. Your objective findings are going to be pretty much the same. Your MTK test, your Hawkins Kennedy test, and then you can use to differentiate. Management, you can start with gentle isometrics of your shoulders with degenerative injuries or degenerative tears. Gentle isometrics are a good start to engage, and then you can use a symptom modification test like we have discussed last time using a TheraBand. Do you want me to explain that today as well, or should we just leave that to that point when we discuss the shoulder conundrum? What do you
Yeah,
guys
I
say?
think my suggestion is when I'll be discussing that again, then you can
Yeah,
present it because you have
yeah,
the therapies.
yeah.
Yeah.
So then you use your different symptom modification test where what you're doing. Like I have already explained it, the biomechanics of the shoulder in this picture, which is not a very good looking picture, however. So I'll just use it on myself because of the inhibition and being in pain behaviors, your muscle, this term is called muscle patterning, abnormal muscle pattern behavior development, where I've already told you about your plab muscle. You remember your plab muscle, your pectoralis major, your latissimus dorsi, your anterior deltoid, and your biceps. They get over recruited, so they will be tight. They will be overworking. Okay, and your posterior shoulder, which is your
Infraspinatus
posterior
teres
rotator cuff,
minor.
yeah,
Yes.
teres. They will be inhibited.
Yeah.
Okay, and your stabilizers, which is your paraspinal muscles, your tricep muscles, and your there's a third muscle as well. I can't remember the name.
Subscapular.
No, 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 no. Tricep,
Latissimus
your rectus
dorsi.
spinae muscle. No, latissimus dorsi is your prime mover, your global mover.
Global mover.
It's in my mind, but I'm
I have
struggling
learned
to.
this, inshallah. But that's
Yeah,
good that you have mentioned all these.
yeah. Just I've made a mnemonics. Plab is your global movers. Okay.
Hmm.
Sorry, your serratus anterior.
Oh, yes.
Hmm.
Very
Your
important.
stabilizer, the most important stabilizer. How can I forget about it, guys?
Last time, remember, I was keep on telling about serratus anterior, serratus anterior.
Serratus anterior. Yeah,
Yeah.
serratus anterior. If
Hmm.
you guys remember.
Yes.
Right. Just a minute. I'm trying to open a very nice document. I'm confirming that. Sorry, guys. Your local stability is your rotator cuff, stability and mobility rotator cuff, and serratus anterior is your local, not a global. So your global one is your tricep muscle. जब तक अब मेरे जेन में आएगा नहीं ना, I will be. You can crop that, Candy, when you do your video. You can crop this bakwas. See, yes. Your lower
Lower.
trapezius muscle is your uh, global stabilizers. Okay. So
Lower.
when you do your symptom improvement test, you put TheraBand around your hand and you ask the patient to resist it and elevate your arm. Now, with that, you're going to ask them to step forward with their opposite leg. Okay,
Hmm.
that will recruit your whole posterior chain. And when you recruit your whole posterior chain, meaning all your spinals, all
Mhm.
your trapezius, lower trapezius muscle that's connected down to your latissimus dorsi, and then latissimus dorsi is connected to your iliac, iliac crest, and that is connected to your glutes. So this is the whole chain that you're recruiting. Okay, so when you recruit your whole chain, you're giving the somatosensory signals to your inhibited muscles, which are your posterior cuff muscles. So as soon as you will ask them to start doing their work because they're sitting lazy, don't not doing anything, you activate them, it takes the load off from your interior muscle. So imagine you've got you've got a heavy thing to lift and you've got four people to lift it and two people are not doing anything and two people are ending up to do the all work. They're going to be painful. Okay, it's going to be difficult for them. So when all of them are recruited, you will see a symptom improvement in 5 minutes. If this exercise, for some people, remember, this symptom improvement test works. However, it's not necessary that this will work with all of the people.
Mm.
So for the
Yeah.
people it works, this will be your exercise as well to start. You can add that into your exercise plan to rehab their rotator cuff. Okay, so you can do all sorts, use your symptom improvement tests, and as soon as you use your symptom improvement test, your patient will start. Even after 3 to 4 weeks, I have seen there's massive improvement in patient symptoms. And
MashaAllah.
and that's how you start your rehab. So your rotator cuff rehab, I'll just give you a summary. Lots a lot of posterior cuff. So this exercise is really good, where your shoulder is supported on a table and you give them a water bottle or anything and they do this external to internal rotation movement. This
Can we
increases your
increase the weight,
rotator cuff.
like 1 kg weight or
Oh
0.5
yeah, yeah.
kg?
Well, first I ask them to do without any weight, just
Okay.
to give it a little bit of, and then add, then progress themselves with like a tin of beans, like can of beans and stuff,
Hmm.
and then add some weight like a water bottle. Depends patient to patient. If it's an old patient, I would start with a can of beans. But if it's a
Hmm.
young patient who already do lots of dumbbells, I might just start straight away start with a water bottle or 1 kg dumbbell, and then
Yeah.
from there you go.
And
So
sorry,
yeah.
with the recruiting, you mean to activate the muscles?
Yes, yes.
Yeah,
Because
yeah.
normally, I'm going to read more about it as well. I was just searching about muscle patterning. Why I'm having my tongue is slipping. So muscle patterning is where what happens. मतलब कोई भी injury होता है ना. I'm going to explain it
Hmm.
in Urdu.
No
Simple
problem.
सी
Yeah, go
injuries
ahead.
will
Mm-hmm.
disturb the whole mechanics.
Yeah,
Because what
obviously.
happens, that coordination between your brain and your muscle and that somatosensory coordination gets disturbed. एक भी इंजरी जो है उसके लिए
Hmm.
फिर क्या होता है कि आप जब when you get injury in one thing, the other thing that's working gets to compromise for that, and फिर उसमें issue आता है, फिर the one that's connected to, and it's like a domino effect. It's effect.
Hmm.
So the minute you go and you sort of treat that prime issue जहां से आ रहा था, बाकी सब automatically ठीक हो जाता है. समझ आया?
Perfect.
So you
Mm-hmm.
start it's similar जब आपका knee में patella tracking होता है. I think patella tracking is got the same, जिसमें I think the control of your vastus medialis muscle is because that goes a bit lazy, and then you get over recruiter of your lateral muscles. I'm not sure
I
about
think
it, but something
we
like
can
this
we
happen
can
and your patella
include that
starts
in our
to.
CD.
Hmm?
We can include that
Don't.
in our CD.
हाँ, ये होगा, एक पोर्शन होगा. ठीक है.
Yeah.
Candy, when you obviously do that, you can. Oh wow, Uswa is here.
Finally.
Welcome,
Yeah.
Usma. And now we are
Welcome.
finished with our CPD. Yay!
Yay.
I
Welcome. And
think
she's
I
gone.
think every time there is some problem with Uswa. Whenever she turns in, she just disappears quickly. I don't know.
I think it was happening to me as well, but then you gave me a call. So
So
it's
so
saying yes
Uswa
or
is
wait.
testing my patience. Every time she's sending me request, I have to go into the lobby.
Yeah,
But
I
Welcome.
also went into
I hope
lobby,
you're
I
here.
think.
now she's
Yeah,
here
she's.
now.
Mm-hmm.
still here?
But we can't see her. Oh, she's gone again. Whoo, vanished.
Guys, वैसे I'm done.